I'm very, very happy and feel honored to introduce none other than Dr. Giridhar Anantaraman, who needs no introduction to this audience, but nevertheless the protocol demands that we do it. And we all know he's synonymous with PCV, and he's a senior Vitreo-retinal surgeon at the Giridhar Eye Institute, and he's the founder and the managing director. He completed his MS ophthalmology in Chipmur, Pondicherry. He did his DO and MS in Pondicherry. He did fellowships, the long-term fellowship in 1984 from the famous Shankar Netralaya in Chennai, and he did a short-term fellowship in 1991 in vitreoretinal diseases at the University of Wisconsin, Madison in the US. He has more than 80 publications in peer-reviewed journals. He's been author of multiple textbooks. He's held multiple positions, just naming a few here in the interest of time. Been the president of the Kerala Society of Ophthalmic Surgeons, Cochin Ophthalmic Club, member of the Scientific Committee of the All India Ophthalmological Society, and more importantly to VRSI, he's been the honorary secretary of the VRSI in 2011 to 2014, and has been the president of the Vitreo-retinal Society between 2016 to 2018. He has innumerable number of awards and honors that he has received. Due to the paucity of time, I'm just naming a few of them here. Starting from his early career, he's been receiving awards. He's received the 2014 Distinguished Service Award from the Asia Pacific Academy of Ophthalmology, Trichur Academy of Ophthalmology Oration Award, the ASRS Honor Award 2017. He's been received, and 2018 Co-Retina for his exemplary oration, debate on interesting topics to retinal surgeons in UAE, and 2019 he had received the AIOS IJO Gold Award at Indore. He is not only a wonderful clinician, but he's been involved in innumerable number of pro bono services, has been touching lives. He's a great humanitarian and has been doing a wonderful human service to this part of the Kerala. So the Vitreo-retinal Society is very honored to present the Dr. PATNAIK Oration Award to Dr. Giridhar Anantaraman.
I invite Dr. Giridhar Anantaraman onto the dais. I request Dr. N.S. Muralidhar, President VRSI, to do the honor. I would like to request Dr. Giridhar sir to deliver the oration.
A very good morning to you all, dear members of the Vitreo-retina Society. I'm extremely grateful to the governing council of this society for having conferred on me this prestigious Oration Award, PATNAIK Oration Award 2023. As I had written in my reply letter to the VRSI, this probably is the single most important milestone in my nearly 4 decades of professional career, and it is an acknowledgement. It is not something that I aspired for. It is an acknowledgement of the years of hard work that me and my high team has consistently done at the Giridhar Eye Institute. The topic I chose was polypoidal choroidal vasculopathy from bench to bedside, meaning from laboratory to the clinic. The lab here is the retinal imaging lab, and how we can translate what we are seeing in the imaging lab to our clinic is the crux of my presentation. I have no financial interest. Our ties with PCV began more than 2 decades ago, and about 15 years ago we published our first presentation at a time when our knowledge about this disease was in infancy, and many of the cases we were missing and treating as central serous chorioretinopathy or classic wet age-related macular degeneration. In a series of 47 eyes of 45 patients, we described the clinical features and showed that the exudative or the pseudosanguineous variety was the most common, and indocyanine green angiography was diagnostic, and photodynamic therapy with anti-VEGF or triamcinolone was probably quite effective in the treatment of this disease. Recently, we updated our EMR data, and we had a total of 1,024 patients, of which I'm just presenting some interesting observations which may kindle some interest in all of you, of 523 patients. 41 of these had bilateral disease. The mean age was 65. The youngest in this group was 32 years. The oldest was 91 years. About 5% of these patients were below the age of 50 years, much younger than the patients that we see normally with wet AMD. As we had seen in our normal old cohort, 62.9% had exudative disease, and therefore there was no difference as far as the clinical presentation is concerned. And this is a very important information because pseudosanguineous variety, if diagnosed and treated early, can persist with very good visual acuity. My presentation flow is basically to describe, are there any different phenotypes of PCV? Is there a relation to choroidal thickness, and is it truly a pachychoroid disease? And is the course and treatment in the long term very different from classic type 2 or type 3 macular neovascularization? In the group less than 50 years, where we had 22 patients, interestingly more females, whereas in the total overall data, there was no particular sex predilection. The mean age was 45.54. This is the Excel sheet, and if you see this Excel sheet, half the patients have hemorrhagic variety, and therefore the PCV that comes in the younger age group probably is more hemorrhagic or more dangerous and can result in substantial loss of vision. I'm showing you some cases from the series. In a 45-year-old patient who had already lost a fellow eye to a subaqueous hemorrhage, you can see the sort of the polypoidal clusters that we see right in the fovea, resulting in significant hemorrhage, and these are very resistant to treatment. This is a second patient, the youngest in our group, a 32-year-old software engineer from Hyderabad, who came to consult me for a second opinion, who had been made multiple diagnoses of central serous chorioretinopathy and inflammatory CNVM. And when she consulted me, this was the picture where there was a tinge of submacular hemorrhage just around the fovea. As you can see, an decreased autofluorescence right at the fovea. And when we did the ICG for this particular patient and the eye tracking ICG, you can see the tall peak PED with hyperreflectivity, very diagnostic of PCV, thereby telling you that it can occur even as young as a 30-year-old patient. This is another interesting case from the same series where this patient was seen with a slight distortion of vision in the left eye, had a PED with no fluid, and the patient was requested to come for regular follow-up, but she was lost for follow-up but came 1 year later. And when she came 1 year later, you can see the OCT here showing you the tall peak PED and serous macular detachment, diagnostic of polypoidal choroidal vasculopathy. Looking back at the earlier PED, you can see this PED was slightly hyper-reflective, and there is a slight irregularity of the retinal pigment epithelium. Therefore, it only emphasizes our need to carefully look at some of these images, and some of these PEDs that we looks as innocuous may be harboring disease. And this is some of the pictures from the same patient where we're showing you the diagnostic features of polypoidal disease. Therefore, polypoidal disease in the young less than 50 years has got distinct clinical features. They are predominantly hemorrhagic, could mimic central serous chorioretinopathy, and they are predominantly polypoidal. Therefore, I have described one set of phenotypes of polypoidal disease. Indocyanine green angiography is slowly losing its importance in PCV because of good SD-OCT. But personally, I feel to describe the morphological features of polypoidal disease, it's very necessary for us to do ICGA. because ICGA can demonstrate different morphological features. One is what we call as the aneurysmal type, where you have a large neovascular network ending in small polyps. Now these are less dangerous because they usually cause serous maculopathy. And if you look at the OCT, you can see the polypoidal and also the double layered sign throughout the network and also the polyps. We had described in a paper a couple of years ago the evolution of aneurysmal polypoidal PCV. Just as I just showed you how a PED can progress into a polyp, this is a case, a fellow eye of a patient with polypoidal disease where the flat irregular PED slowly increases in size. Probably if you do an octa at this stage, you will see a neovascular network now. But it is slowly increasing in size. The fluid is appearing, but at that time the ICGA is not showing any polyp. But as time goes by, you can see the evolution of the tall peak PED and the ICG finally confirming PCV. Therefore, I am just showing you a case, and in this particular paper we had shown multiple cases of evolution of aneurysmal PCV. Therefore, PCV has got different phenotypes, and this again has got clinical and prognostic implication. One is the aneurysmal type with a larger lesion, and its other, which is more dangerous and can result in hemorrhagic disease, is the clusters of subfoveal polyp, which are more dangerous and result in large submacular hemorrhage. In our series, aneurysmal was more common than polypoidal. Another important differentiation is the results to treatment. Now, this is a patient with polypoidal PCV. You can see the large clusters here on the left this side, and after 5 monthly injections of aflibercept, there's a decrease in the number of polyps, but the disease continues to be active, meaning thereby these patients require more anti-VEGF injections, and probably PDT combination therapy may be a useful treatment. On the other hand, you can see this patient with a neovascular network ending in small polyps here. After 3 doses, you can see there is complete resolution, not only of the lesion, but also of the features that we see in this particular disease, just showing you that how aneurysmal type responds better to treatment and probably may need lesser number of injections. Is PCV a pachychoroid disease? In our series, we found that 16.5% of these patients have a very small choroid, and only about 23% have really a thick choroid. Therefore, we are dealing with a disease where at one end of the spectrum we have a picture like this, a serous macular detachment in one eye, a PPE, probably call it a pigment PPE type picture in the other eye, and subsequently you can see this particular patient where you see the serous macular detachment, you see this thick choroid here and a large pachyvessel compressing the inner choroid, and this double layered sign here in one eye, and the other eye showing you classic features of PPE where you can see focal areas of RPE disruption and a thick choroid. And the other end of the spectrum is this particular patient, a 75-year-old lady with a very thin choroid, just about 116 to 125 microns, with large peak PED and serous macular detachment, showing you a beautiful polypoidal lesions and also the clinical photo showing drusenoid changes. Therefore, not all PCV is pachychoroid, and only a small percentage of PCV is truly a pachychoroid disease. My last point is the course and the treatment. Out of the 523 eyes, more than 100 eyes had more than 5 years follow-up, and nearly 52 eyes had 10 years follow-up. For want of time, I'm not in a position to give you all the results, but I'll just show you one particular case with a 17-year follow-up of bilateral disease who has been under my treatment even now. Now, this is a patient where the left eye was diagnosed in 2009, the right eye was diagnosed in 2006. That time we were using the camera ICG, and therefore you can't see the polyps very well. The patient has, you can see the OCT, which shows you the classic features. This patient had a PDT combination therapy in 2009. After 4 years, she had a recurrence, and she had a second dose of PDT. And subsequently, she had 2 more doses of PDT. And then she was shifted to anti-VEGF injections like aflibercept. And with aflibercept, of course, there is polyp closure, but doesn't last very long. So between 2016 and 23, she had 2 more sets of PDT combination therapy with aflibercept, and subsequently she is on aflibercept PRN treatment. The story of the left eye in a nutshell is this, where after 40 months interval between the first and second cycle, and totally at 31 anti-VEGF injections and 5 cycles of photodynamic therapy and combination therapy. At the end of 14 or 15 years, she still has got good visual acuity of 6/9. You can see the fundus today. It just looks reasonably good. And regarding the right eye, she has received 2 cycles of combination therapy and 22 anti-VEGF injections. I just want to show you the OCT very recently, just to tell you, unlike type 2 and type 3 macular neovascularization, we don't see outer retinal atrophy in many cases with polypoidal disease. And we have a series of patients like that. Even after 16 years of treatment, you can see here the patient has got reasonably good structure. And you can see the foveal thickness is nearly normal. And although there are focal areas of ellipsoid loss, definitely there is no significant outer retinal atrophy that we normally see even in patients with type 2 and type 3 in spite of consistent treatment. Therefore, friends, I've just tried to highlight some of the unanswered questions in polypoidal disease. Many of these observations require validation, but then still I feel this is a distinct clinical entity in many patients, and probably if all of us can work together, we can contribute more to the literature as far as this particular disease is concerned. Before I conclude, I would like to acknowledge all our fellows over the years who have been instrumental in creating this huge database and image bank on this particular disease across the country, and also my team at the Giridhar Eye Institute, the technicians, the photographers, the optometrists, and the consultants, without whose support I will not be standing here today. Without this talk will be totally incomplete if I do not pay a homage to my mentor, Dr. Badrinath, who passed away recently. We had a guru 6-year relationship for many, many years, which finally turned into a family friend. He was part of our institution. He has visited our institution many times, and really we miss him on this particular day. Thank you all for your kind attention. I hope this lecture.
Thank you, sir. Now I call upon Dr. Manisha Agarwal, Secretary VRSI, to introduce the Dr. S.S. Badrinath Orish Award.